to have you with us, and we must be going on because we're a little bit late.
Thank you very much for the opportunity. Looking forward to David's talk. Thanks.
And the next lecture is going to be delivered by David Whitcomb from Pittsburgh, Pennsylvania, United States, and it's going to be an accurate prediction of risk of organ failure within the first day, acute pancreatitis, using a mathematical modeling and a smartphone. It's going to be very interesting.
Okay, before I begin my talk, first of all, as far as Dr. Hege and Dr. Sahun Toth suggesting it's the acinar cell or the duct cell, it's like walking. You need a right leg and a left leg, and they better both be strong and be synchronized to have any good effect. Secondly, is that we've done multiple trials. We just published a trial of early rectal indomethacin, which is a randomized trial, had zero effect. I tried a study on a calcium channel blocker, amlodipine. It was off patent. Nobody would pay for it. We could not get it through. We've initiated an international study called Apprentice to find out what the differences of practices are around the world to see if we can come up with a better harmonization and those types of things. And so I think there's a lot of activity going on. My talk today is I'm going to focus on what the real problem is and why everybody's failing. And unless you think about things the way I'm thinking as a dyslexic, there won't be any progress. And we don't make progress unless we realize what we're doing is wrong and change it. So I'm going to begin with my conclusions. And that is acute pancreatitis is an involving inflammatory process. All the major complications are linked to pathologic vascular response to inflammation and injury and a capillary leak syndrome. The first 6 hours are critical to classify and initiate treatment for acute pancreatitis, which in trauma is called the golden hour. Now, what the trauma surgeons will tell you is that if you don't stabilize the patient within the first couple hours, what you do for the next weeks have little effect. You've got to treat them early, and the trials we've seen in acute pancreatitis start therapy at 72 to 96 hours. The horse is out of the barn already, and it's too late. The revised Atlanta criteria, which is the gold standard, are not reliable at all in early disease. We have to reject the Atlanta criteria. SEERS precedes multi-organ failure in most cases, but it has a very poor predictive value. The modified Marshall score, which is used in the revised Atlanta criteria, should not be used to classify patients within the first 24 to 48 hours, and new tools are needed to rapidly and correctly classify acute pancreatitis by etiology and by the likelihood of organ failure at the point of care. So I work at a tertiary center, and if somebody has acute pancreatitis and comes to Presbyterian University Hospital when I or one of my colleagues are on call, they do extremely well. But God forbid they go to their local hospital and they don't find out they're in trouble until day 2 and then send them directly to our intensive care unit. You have to treat at the point of care, and the model we should be using is not for pain control and chronic pancreatitis. It's multiple trauma model. It's an acute pancreatitis model. It's a stroke model where it's an emergency to get the right treatment immediately, and there has to be a system at the point of care where the patients that are in deep trouble are recognized immediately, and there are protocols and clinician support tools to make sure the right thing is done early. The beauty is that everybody has one of these, everybody. It's a smartphone, and if the patients are old, at least their doctor has it, and there's access to all the information in the world if it's organized and presented in a logical way. So let's go back and review acute pancreatitis. It's a sudden and acute inflammatory response of the pancreas. It's linked to trypsin activation at the very beginning, but once that happens, it becomes irrelevant because you've started the ball rolling. It causes severe abdominal pain, often with vomiting, but without headache, which is a neat trick. If they have a headache, it's probably the flu. The elevated serum pancreatic digestive enzymes In a severe acute pancreatitis, there is up to 20% mortality. The pathology of severe acute pancreatitis is poorly understood, but we know that systemic inflammation is important, and you can limit that with enteral nutrition. Multi-organ failure can be reduced with fluids, especially lactated ringers, and the first 6 hours are the critical golden hour. So the advantage of acute pancreatitis versus multiple trauma is that it's an evolving process, whereas trauma hits immediately. It takes a while for the injury to build up in acute pancreatitis. The bad part is if you're in multiple trauma, you know immediately. If you have acute pancreatitis, you don't. And so there's a lag period, and we have to be aware of that. So death usually requires systemic inflammation. This is the cytokine storm, and there's basically clinical features that are used to determine this. Now, the bad thing is they're nonspecific. The good thing is anybody in the world can measure it. SEERS is seen in sepsis, multiple trauma, burns, and the COVID-19. And organ failure in most cases requires persistent SEERS. So you don't know until 48 hours that it's persistent. And it's too late. So the dynamic process is important. You have injury, pro-inflammation, anti-inflammation, and resolution. The severity is major damage to the pancreas, cytokine storm, SEERS or sepsis physiology, and most of what we've learned is studying sepsis, not pancreatitis. So there's some important differences in multi-organ failure. So it starts with anything that causes the injury to the pancreas. We have pancreatic injury, trypsin activation, tissue damage. The tissue damage causes a local inflammation, which has several different phases. The early phases is pro-inflammatory and actually causes more tissue damage. But during this process, it evolves into a middle phase where the anti-inflammatory response begins to take effect. And finally, the anti-inflammatory phase dominates, shuts off the pro-inflammation, protects the tissue, and you begin healing. However, in some cases, you have severe acute pancreatitis, and the inflammation goes outside of the pancreas and causes SEERS, which can lead to the capillary leak syndrome. If you have capillary leak syndrome, it also affects other epithelial cells. You have pulmonary edema, hypotension, and shock. That's what leads to pancreatic necrosis, acute kidney injury, gut ileus, and bacterial translocation, which is part of a gut leak process. And in fact, in dog models, if you ligate the lymphatics, you can prevent persistent SEERS, suggesting that it is the leak of bacterial products in the gut that drives persistent SEERS. And so you end up with a vicious circle here that eventually gets better or the patient dies. So we can use fluids to treat the shock, and we can use enteral nutrition to help with the gut bacterial location. What I'd like to point out is that the timing is pretty fast. You better have your therapy on board by 12 hours. And secondly, the decision about whether or not you have SEERS and organ failure depends on whether or not you get capillary leak syndrome. And so we are wondering, is there a disconnect between the two, because you can't predict what's going to happen. In animal models, you can. In people, you cannot. We looked at Angiotensin II, which is a marker of endothelial cell injury. And this is a study we did in collaboration with Marcus Lurch and his group, and showed that the patients that develop multi-organ failure have a markedly elevated level of Angiotensin II versus those with SEERS that did not develop organ failure from day 2 to day 7. And so this suggests that the transition between the cytokine storm and organ failure has something to do with endothelial cells because of this massive release of this paracrine called Angiotensin II. So what is multi-organ failure? Well, we look at the lung, the cardiovascular system, kidney, and pancreas. And so I built a compartment model, a dynamic compartment model, in order to structure our thinking about it. And what we normally see is a heart. It has arteries. It goes to a capillary bed. Venous side comes back to the heart. There's the pancreas and the kidney, part of the visceral organ systems. What happens in the capillary bed is there's higher hydrostatic pressure. It pushes fluid into the interstitial space. It concentrates the protein On the venous side, where the hydrostatic pressure is low, oncotic pressure draws fluid back in and the blood returns to the heart. There are some larger pores in which some albumin can leak out. Fortunately, the albumin is picked up by the lymphatics and returns to the heart, and the oncotic pressure is retained. The question is, if we add another capillary bed that has a very large diameter, allowing large proteins to leak out, what would we predict would happen? And what we predicted is that there would be a loss of all proteins, a drop in albumin and non-albumin plasma proteins, which are the large molecular weight. Hematocrit would go up. The return of the venous blood to the heart would be reduced. You would have hypotension. You would have edema in the tissue, especially in the lung, and the lymphatics could not return the proteins fast enough. In addition, you'd have a loss of proteins in the third space and end up with hypotension. And so we took patients that we had carefully studied, and we looked at this, and we did a trial. And what we did is, instead of taking the average of the population to get our standards for hematocrit and hemoglobin and albumin, we used the own patient as their control. So those patients in which we already had clinical data before they had acute pancreatitis, we took their pre-admission hematocrit, blood urea nitrogen, creatinine, albumin, and non-total protein, and then non-albumin protein, which is total protein minus the albumin, and we calculated those, and then we put that through a model using each subject as their own control. Because what clinicians know, if you ask somebody what their hematocrit is, it's anywhere between 30 and 50, and you can't know without measuring it. And if you measure it suddenly without any context, it's impossible to interpret. We had 57 subjects that had all the criteria. Of these, 18 developed multi-organ failure and 19 did not. It turned out that hemoconcentration was extremely accurate compared with pre-admission levels. If your creatinine went up 5 on the average, it increased. In non-multi-organ failure, the hematocrit never went up. So if you had a marked increase in hematocrit, that was a good sign. If you had a hematocrit that went over 3, it distinguished multi-organ failure from non-multi-organ failure with an odds ratio of almost 18. So that's a pretty stinking good measure. And it's only if you do with your own patient, because if you use the population-based cutoffs of 40% higher than 43%, 36% women, men, none of them are significant. It's only if you use the patient as their own control. Secondly, we looked at the capillary leak syndrome and looked at what happened in patients that had severe acute pancreatitis in red versus, multi-organ failure versus Sears without multi-organ failure. And what we saw was that there was an increase in BUN, blood urea nitrogen, and creatinine, but they increased together, which meant the kidney failure was not kidney injury initially, it's pre-renal azotemia. That means the visceral organs are being hypoperfused during the early course of acute pancreatitis. We also looked at the patient's albumin and protein, and what we found was that, as the Hungarian group also showed, is the albumin goes down, but it goes down fast with patients with multi-organ failure. In patients' total protein, it actually stays constant until 24 hours and then plummets. The ratio of albumin to protein to total protein also is important, because what it shows is there is an early concentration of the high molecular weight proteins, because the albumin's lost first, causing, just like the hematocrit goes up, the total protein goes up, and then suddenly the large proteins plummet. Where's the large proteins going? Well, we believe they're going into the interstitial space because they drop and stay low for a long period of time. So the basic criteria is, if you have a hematocrit that increases greater than 3 from baseline, you have a high probability that the person is in multi-organ failure. If there's an increase in the BUN and creatinine from baseline, it is pre-renal azotemia. And an early drop of albumin, an increase in the non-albumin protein from baseline indicates this capillary leak syndrome with a pathogenic drop 24 hours. So let's go back to the revised Atlanta criteria. We define the pancreatitis with abdominal pain, lipase, and imaging studies. The types are the interstitial and necrosing pancreatitis. The complications focus on the respiratory, cardiovascular, and renal. Severity is mild, moderate, and severe. Moderate is organ failure that doesn't persist. Severe is organ failure that does persist. So let's look at this organ failure. And again, they use the modified Marshall score showing mild acute pancreatitis, moderate, and severe. But if you look at the persistent organ failure, the modified Marshall score of 2 or more in an organ system, and here's what it is. You have to have a hypoxia, which means you've already developed severe pulmonary failure. So this is, you have to be pretty sick before you hit this criteria. The renal, you have to have a creatinine that rises 1.9 or above. The problem is you can take the kidneys out and the creatinine takes several days to rise. Also, you don't know where the starting creatinine is. So trying to use a cutoff at the time of admission is absurd. It's completely absurd. Finally, the cardiovascular shows a systolic blood pressure less than 90. You get 1 if it's less than 90 and had fluid resuscitation, and less than 90 that's not fluid responsive, in order to get 2 with cardiovascular. But this is with sepsis. This is with peripheral hypotension, where there is a high output failure. That doesn't occur in acute pancreatitis, where they're more likely to have hypertension, especially since that seems to be predisposing. Very rarely do we see people with hypotension unless they have no blood left. And so all of these are very late, they're too severe, and they're not useful for classifying patients. And if anybody would like me in the question and answer period, I'll repeat the same thing. So Sears has a very poor predictive value in itself. As a matter of fact, the severity predicting AP, the positive predictive is 7.5 to 4.9%. That's terrible. You can't use Sears to predict. It's necessary, but not sufficient. Multi-organ failure can also develop without Sears, which we see in hypertriglyceridemic acute pancreatitis because of the release of toxins directly that affect the endothelial cells, causing vascular leak syndrome. The modified Marshall score for pulmonary is too severe. For cardiovascular, it's too severe, and it's designed for sepsis, not for acute pancreatitis. And for renal failure, it takes several days for the creatinine to rise, and so it's no good at the time of admission. So the difference between the transient and persistent organ failure also requires waiting for 48 hours to determine whether or not you actually have multi-organ failure that's not going to reverse, and you've missed the golden hour by 2 days. This is ridiculous. This is why everything's failing. We have the wrong model. We're doing everything backwards instead of proactive and forward. So what are the future directions? Well, first of all, we looked at all of our cytokine data, and it turns out that if you pick these factors, you have an incredibly high accuracy that outperforms any individual cytokines, laboratory tests, and scores. So Chris Langmead is a computer scientist at Carnegie Mellon University does AI and that kind of thing. But that was extremely important. And turns out that IL-6 is probably can substitute for some of these. It's also a good marker. So what I'm going to talk about today is the ADAPT tool. And this is the Aerial Precision Medicine Acute Pancreatitis Tracker. And this is available anywhere around the world if you have a smartphone. So basically, what I've done is I gave up trying to work with big institutions because they don't want to change. So I started a company, Aerial Precision Medicine. So I'm 75% at the university, 25% at Aerial Precision Medicine, where we can have people actually build what we want. It's not funded by a NIH grant that you can't get the thing funded. If you do, you can't get it renewed, and there's hiring people and firing them, and it's just a ridiculous process, and it's not maintained. So we've built this model based on this clinical pathway, and specifically, this focuses on acute pancreatitis. So if you go to the acute pancreatitis in this smart thing, what happens is you can actually take information that's available almost anywhere, and there's a guide to what to order and when, and it tells you if you have enough information using a whole variety of scores to predict with a 95% certainty whether or not a patient is likely to have multi-organ failure. Now, this particular case I thought was pretty interesting because this patient was predicted by Marshall score to have mild acute pancreatitis and was put on the floor. Fortunately for them, it was a Florida Presbyterian hospital. When the attending physician rounded the next morning, they said, this person is in deep trouble. We want to immediately bolus them with fluid and send him to the intensive care unit where the person was beginning to crash. We were able to salvage them, and they spent a couple of weeks in the intensive care unit and survived. So using the Marshall score, if that person would not have been at our hospital and had one of our attendings look at them, they would be dead. They would have an IV running at 100 cc's an hour up on the 3rd floor, and the nurse comes in the morning and they're dead. And I've talked to a number of people that we've seen that, or we have people transferred to our hospital where they're able to resuscitate them, but they were in trouble, and many of them are in the hospital for months, as you know. And so the way it works is an MD is working in a rural hospital, and the patient says, oh, I have abdominal pain. They evaluate them in the emergency department, think, wow, you know, the symptoms could be acute pancreatitis. They have an elevated amylase and lipase. They log in. The calculator starts telling them, what do they need to order? How often does it need to order? What do the experts say? It can be balanced off with patient-specific and case series databases, and then the physicians that need to be involved can immediately link on as well and track the patient with them. More importantly, it also alerts the physician that the patient may be eligible for a research criteria, immediately identify the clinical research coordinator who can look at inclusion-exclusion criteria, and then activate the research team so you can actually do a clinical trial when it matters. This patient can be followed throughout the hospital, and the outcome can also be tracked as well. So this is something you just can't do at the university. You have to do industry. Industry is not interested. So I started my own company in order to actually get the tools I need in my day job at the university to help patients with acute pancreatitis. And then, of course, prevention of recurrence is important. We've talked about most of these issues of addressing the patients with biliary disease, older patients, hypertriglyceridemia, which is often overlooked. You want to push that forward, and genetic testing is necessary if the etiology is unclear. So I think that what I've tried to do is explain why everybody's failed for the last 50 years, what we need to do to change it, why there's no available tools, why our concepts of what multi-organ failures are is incomplete and wrong, because it's not just the cytokine storm. It's another factor that's causing vascular leak syndrome in some patients, but not others. And it's a severe vascular leak syndrome. And if we understand that and change our targets, treat early, we can save lives and prevent serious organ damage and long-standing effects, including death. So in summary, it's common, it's potentially lethal, inflammation is involved, multi-organ failure is delayed by multiple hours from the onset of inflammation. Early evaluation of the severity and etiology is critical. Multi-organ failure requires SEERs, but also has to involve endothelial cell damage, which is not directly linked to inflammation, which is necessary but not sufficient. Fluid resuscitation should be given to those people who need it. It shouldn't be given to people who don't need it. What the right resuscitation fluid is still being debated. And in the future, an electronic tool for dynamic of evaluation of acute pancreatitis is needed and being tested. Thank you for your attention.
Thank you very much. Excellent talk. And the paper is open for discussion.
Thanks, David, for a very insightful talk. And we discussed this already yesterday evening. I very much like your approach of getting away of the regression to the mean, which is hampering medicine in general. If I understand you correctly, so your tool takes into consideration pre-admission values. So any pre-admission value you can get from the patient gets fed into your system.
Yes.
Yeah. What do we know about the variability of each of these individual parameters in a person over time?
Yeah, so excellent question. So basically what the tool does is builds an avatar of the patient that considers their height, their weight, their age, their comorbidities, their obesity, the duration of time, fluid compartments, all those kinds of things, so that because the fluid resuscitation in a 90-pound person is different than a 250-pound person. And so the timing is important. What the model does is continually iterates the ongoing status of the patient so that as additional information comes in, it can adjust and begin doing trajectory analysis, because that's what we're trying to do. We're trying to understand where they're going and how to change that. And so the model is more of a dynamic mathematical model rather than a data-driven model based on the mean of a heterogeneous population. And that makes it incredibly more accurate. You can also identify the etiologies, because it turns out the clinical course of patients with hypertriglyceritic acute pancreatitis, alcoholic acute pancreatitis, biliary acute pancreatitis, and idiopathic acute pancreatitis are different. It's not the same thing. There's overlaps, but so those are the types of things that we can begin doing. We can use population data to sort of get the general parameters, but using supervised machine learning allows you to begin understanding how these different subsets are going to react, and you can at least begin with some general parameters. And so right now, what actually the Hungarians have shown, if you just follow a simple protocol and give them fluids, you do better. So we think we can do a lot better. But what's very important is that it also allows you to tie into the electronic health records, so you can immediately pre-upload previous information, current information, add information as it comes out of the laboratory, and determine whether or not the patient is eligible for a clinical trial. And if it is, inclusion and exclusion criteria are presented at the beginning, not a nurse in the middle of the night trying to wade through the electronic records or whatever. So that's really the purpose, is that how do you present information you need immediately, and how do you adjust for the variability in patients?
David, thanks for a wonderful talk. It was really nice listening. My question would be, you start from the point that you're addressing the golden hour to treat pancreatitis, but that requires that you've established the diagnosis. And if you think about the criteria of diagnosis at the time you would like to treat, I'm not sure that we will have 3 times elevated lipase levels. I'm sure that there are no changes to imaging at that point. And yes, we might have pain, but it's the most unspecific symptom. So basically, I think one of the reasons why we start with a symptomatic treatment in this situation to stabilize the patient is because we can't make a clear diagnosis. And therefore, yes, I totally agree that all the markers and all the scores we were using are coming too late, and they're less good than an experienced clinician. And I mean, this has been shown before. The score is a bore. Do we really, can we really start with a specific treatment in the absence of a diagnosis? And this is what I would like to question.
The answer is, of course not. And the reason people come to the hospital is they're having severe abdominal pain, and the amylase and lipase are already beginning to rise. So what happens is that if they're above normal range, the person has abdominal pain. By definition, that is acute pancreatitis. You don't need the imaging. What? Absolutely. And if a patient has a perforated ulcer, they're not going into Sears. They're not progressing. They're not fluid depleted necessarily. I mean, they may have, if it's been going on for 4 days, like some patients, they have intra-abdominal sepsis, but that's not confused with acute pancreatitis because of the way the onset of pain comes. And the other thing about clinical medicine is that you can never be 100% sure of everything in the emergency room. You go with high probabilities, especially if it's bolstered with 50 years of experience and data to sort of get you in the right parameter.
Yeah, but then again, I mean, you were pointing out, and I totally agree, that SIRS gives you a positive predictive value of only 15% at best. But the negative predictive value is quite high.
Right. So if you don't have Sears,
the clinician really takes into account.
So if you don't have Sears, then you don't put them in the clinical trial. So I agree. So you calculate Sears. It says, so if they do have Sears, then what you want to know, are they going on to multi-organ failure or not? And this is where parameters other than the Marshall score are highly accurate. And we've showed you a 5-panel. There's other things like that.
Very interesting debate, but we must be going on. And another question.
Yes, thanks for the talk. I'm interested in the pathophysiology, obviously, and I like your emphasis on the capillary dilatation and probability increase, which I think is very important. So I ask myself, what is the primary mechanism for that?
Yes.
And one element of it, I think, which actually fits very well with our recent work, is that one element, but probably only one element, is bradykinin, which actually is, of course, released from the pancreas, and pancreas is the major producer of bradykinin. And that would explain a lot of also your pathophysiology. The edema is obviously essential. It increases dramatically the oxygen pathway. And if you do the calculation from the Crope cylinder, you can see that that makes a fantastic difference to the PO2 locally. So I think there's a lot of, from a pathophysiological point of view, very good sense. And I like the approach.
Yeah, well, we have the answer to that, and it's filtering its way through the review process, which is a very slow and painful process. So we have the answer. Keep tuned, and you'll find out what it is.